Cardiovascular, kidney, obesity, diabetes, and other metabolic diseases are increasingly understood as the one connected continuum, often referred to as CRM. This means we are no longer looking at separate conditions, but at one patient with interconnected risk. So what does this actually change in practice? Where does risk start? How early can we act? And what really makes a difference for patients along the journey? Today, we are talking with Paula Seijas Romero, General Manager and Head of Human Pharma Adriatic at Boehringer Ingelheim, about how this approach is already being applied, from prevention and primary care to innovation and system-level change. And if you'd like to explore the broader shift behind this, you can also watch part 1. Hi, Paula. Thank you again to come to our show. Okay, Paula, we talked about IE and a lot of other innovations that we have now available. So sometimes innovation fails. We don't implement it properly. And what, according to your experience, is, let's say, the bigger problems, and what is the problem to get these new solutions?
It comes down at the end to mainly 3 practical enablers. The first one is clear workflows and guideline-aligned pathways. Second is the data interoperability that should flow between primary and specialty care. And the third one, also very important, is the empowerment and training of especially the primary care teams. So when all these 3 enablers come together, everything moves much faster, and we ensure also a better care for the patients, better quality care.
For them.
Yes.
And usually who is giving the care and who is seeing patients more often is primary care physicians. And probably because they have a lot of things to do, they sometimes miss the early signs, and sometimes obesity, some the others miss signs. Why do you think it's happening from time to time?
Yeah, we know that PCPs are the front door of the CRM continuum, yet they are very often under-supported. So they don't have unified guidelines, they lack of unified guidelines, also a structure, screening protocols, decision support tools. Just to mention something, the PCP call to action paper published at the end of 2025 clearly states that PCPs need standardized European CRM guidelines, as well as also screening tools like UACR, EGFR, and NT-proBNP.
Okay, we mentioned that there is several diseases. Also, we have a different stakeholders. We mentioned PCPs, we have professional societies, we have insurance, authorities, and all other. So it's obviously important that they work together. How do you see this cooperation, and what should be done maybe better?
Yeah, so we are entering a period where clearly this collaboration cannot be occasional. It has to be embedded into the system, integrated in the system. We see it also very clear in CRM matters that none of these groups can alone manage important changes. And for this reason, public health authorities, professional societies, primary care networks, and also the industry, they need to all move into the same direction. A first step could be to issue a joint position paper where we define what are the requirements of a CRM pathway to be implemented properly, defining also what is the role of the different stakeholders, and also including the signals for those decision makers, so that they understand and they know where the support is needed in order to ensure an effective implementation.
And do you think that it is happening already, that the cooperation is good, or how long we are from, let's say, optimal cooperation of these? stakeholders?
I think we are on the good track. We are on the good way. There are still things to do, of course, and to improve. But I think especially among the specialists and professionals, healthcare professionals, it is already very clear that these diseases are interconnected and that we have to also have an interconnected response altogether. So there is still way to move, or way to improve, but we are on the good track.
So we started already.
We started already, yes.
Good. And we mentioned in the first episode a lot of innovations that came and that are available for the physician, hopefully to make their job easy and better, let's say. What, according to you, is of this innovation is, let's say, the most important and which need the fastest entering to the system?
Yeah, the most important innovations are those who are really grounded on strong evidence and that can be also implemented on the everyday practice. They move prevention, early detection earlier in the patient journey, and they also reduce the fragmentation across the patient experience, especially for those patients which are more vulnerable or socioeconomically disadvantaged. For this reason, the implementation of a structured cardiometabolic health checks and also this empowerment of the primary care is really important and powerful to make a real impact on the patients and to bring this innovation to patients. So again, early detection is the key here.
And also, EU have a lot of initiatives, and there is a task force with a recommendation, especially focused for cardiovascular, because now cardiovascular is focused on EU. And how is this important early checks for the cardiovascular especially, and how useful are these, let's say, directions?
The new ESC task force has taken an important step, proposing the implementation of a structured cardiometabolic health checks. And this includes blood pressure, lipid profile, also fasting glucose, eGFR, albuminuria, and other lifestyle factors among that. This makes possible that we perform early detection through screening and testing of metabolic and renal risk. With that, if we implement it properly, we can reduce the potential future cases, cardiovascular events, and also this will help also to reduce the burdens, political and also economic, that the healthcare has to also assume in most of the cases.
Okay, we discussed about some changes that is done. We mentioned the new technologies, and you said also that we started good, that we are on good track, but we still have trails to go through.
Yes.
And what do you think is the most important next thing that should be done in the system that are important for the patients of CRM and better outcomes and for across the Europe especially?
Yeah, definitely the most impactful innovation for patients will be to translate all these concepts into real life practice. This means that we implement a structured and standardized cardiometabolic health checks, that we also ensure the implementation of truly CRM pathways in the different countries at national level, and also that we provide to the primary care physicians the tools, the data that they need to ensure that they can implement effectively this early detection. All these pillars are part and are also recognized within the European Union. They are part of the Safe Hearts Plan that places early detection, prevention, and also coordinated disease with the cardiovascular strategy that the EU is implementing. Yeah? So if we achieve these three pillars, we will definitely reduce costs for the system, for the healthcare systems. We will prevent potential cardiovascular events, and we will also ensure a healthier aging of the next generation.
Thank you. So we can expect healthier citizens in the region, in the EU, and when all these changes are implemented. It was a pleasure talking to you, Paula. Thank you.
This is our objective, and thank you for this discussion, Vladen. Thank you.
What becomes clear from this conversation is that the shift is already happening. Across prevention, primary care, innovation, and policy, we are seeing a more connected approach to cardiovascular, renal, and metabolic health taking shape. And with it, new opportunities to support patients earlier and more effectively. Paula, thank you for sharing your perspective and experience. If you find this conversation valuable, make sure to subscribe for more discussions and the future of healthcare, and share this episode with colleagues who are part of this change.